Okay, it is now 12 o'clock, and so we'll go ahead and get started. Good afternoon, everyone. My name is Vineet Chopra, and I am the new chairman of medicine in the Department of Medicine here at the University of Colorado at Denver. It's my pleasure to welcome you to a very special grand rounds today between the Department of Dermatology and our Division of Rheumatology with two incredibly great speakers. So to introduce them to us, I'm going to turn over to Dr. Richard Albert, who is our Vice Chair for Clinical Affairs. Rick?
Thanks, Vineet. We have a tag team match this week with Elizabeth Wallace and JoAnn Zell. Dr. Wallace did her undergrad at Northwestern, graduating magna cum laude. She did her MD at Davis, graduating AOA. Had a preliminary resident at Pacific Medical Center in San Francisco, where she was judged the intern of the year. And then she did her derm residency at Harvard. She's currently an assistant professor of dermatology. Her research interests include phase 1 through 4 clinical trials. She's also been heavily involved providing dermatology care for uninsured patients at the student staff Dawn Clinic in Aurora. Dr. Zell did her undergrad at Michigan, her MD degree at Northwestern, and her residency, room fellowship, and a postdoc in health policy at UCSF. She's currently an assistant professor of medicine and the associate director of education in the Division of Rheumatology. Elizabeth, are you going first?
I'm going to start.
Okay. Take it. Oh, one more point. Anyone who has questions can type them into the chat box and we'll get to them at the end of the talk. Thank you.
Thank you, Dr. Albert. So thanks to the planning committee for inviting us to speak. I know this is a little bit of a different topic, a little more clinical in nature, but we're going to be talking about rheumatology, dermatology joint practice. Oh, I forgot, I don't change the slides. So Liz, thank you. So neither of us have any relevant disclosures. So I'm just going to start with a case. So this was a 49-year-old male who presented with very limited clinical details prior to the admission to the hospital. Looking back in care everywhere, he did have hypercholesterolemia and elevated liver function testing. So here's his timeline. 6 weeks prior to admission, he developed a scaly rash on his dorsal hands and elbows. 4 weeks prior to admission, he developed a new arthritis in the small joints of his hands and feet and arranged a video visit with his PCP, where he was given both topical and oral steroids and was found to be CCP and rheumatoid factor negative. 3 weeks prior to admission, he went to visit his son in Arizona. And then this is just setting the stage of this presentation. So this doesn't have to do with the patient per se, but gives us an idea of what the environment was. So in the beginning of March was when we had the first confirmed COVID-19 case in Colorado. 4 days prior to admission, he saw dermatology for his skin lesions, which apparently had not improved, and underwent a skin biopsy, which was apparently inconclusive. Approximately at that same time, he went to see his primary care provider for cough and shortness of breath and was given a course of oral antibiotics. Then he arranged to be seen again on March 17th, 2020, when he had fever and felt palpitations and was short of breath. He was found in his PCP's office to be hypotensive and hypoxic. EMS was called and he was brought to Memorial Hospital and admitted. In the emergency room, he was described as ill appearing. He had a low-grade fever. He was hypotensive and tachycardic and hypoxic on 15 liters. He was rapidly intubated in the emergency room, and you can see his post-intubation film as shown to the right, where you can see fluffy bilateral infiltrates, right greater than left. Unfortunately, we had no prior films for comparison. Initial laboratory studies showed essentially a normal CBC with a normal differential. His kidney function appeared to be reasonable. He had no anion gap acidosis. Liver function studies were mildly elevated. Albumin was low, perhaps indicating chronic disease, as his synthetic function of his liver was fairly normal with an INR of 1.1. He did have an elevated procalcitonin. His sedimentation rate was mildly elevated. His complements were normal. He had a COVID swab, PCR swab, which was negative. Respiratory panel was otherwise negative, and other tests for infectious organisms were all negative. He was admitted to the ICU and given broad spectrum antibiotics. His pulmonary infiltrates worsened and he was difficult to ventilate. He had an emergent bronchoscopy, which showed straw-colored fluid. All cultures that were sent were negative, and it was monocyte predominant. He was also treated empirically for COVID-19 infection with hydroxychloroquine at the time. He eventually had to be placed in the prone position due to severe hypoxemia, and he had continued fevers. Other laboratory studies started to return. He was anti-nuclear antibody negative, double-stranded DNA negative, which is a lupus antibody. He was positive for Rho52 SSA, which I will address a little bit later in this talk. He was ANCA negative. Other lupus antibodies were negative, JoAnn negative, SCL70 negative, rheumatoid factor and cryoglobulins were negative. Anti-GBM was negative. His CPK was normal, but his aldolase was mildly elevated at 15.5. There was some discussion in the chart of possible dermatomyositis, but there appeared to be some question of how exactly to send the myositis panel from Memorial. Empiric steroids were started, and the myositis panel was sent on 3/26/2020. The patient was transferred to UCH for a second opinion on 3/31/2020 after his admission on 3/17/2020. He was not improving. Apparently, there was some discussion about ECMO, but this was not approved due to prolonged intubation and lack of response to any therapy. On 3/31/2020, rheumatology saw the patient with concern for dermatomyositis, especially the MDA5 variant. At that time, his LDH was normal, CPK was normal, aldolase was now normal, ferritin was elevated at 2,258, and steroids during the course of his admission were off and on due to concern for infection versus autoimmune disease. Here's an example of his CT scan upon transfer. And you can see that he has some consolidation, ground glass opacity, air bronchograms, and then up in the, Liz, I don't know if you can point, up in the left side of his lung, there's this sort of, up a little bit higher there. Yep, there's this sort of lobular thickening, which we deem crazy paving. Next slide. Here's another example of a CT scan at transfer, which showed impressive consolidation, air bronchograms, etc. Next slide.
So the day after, on April 1st, dermatology was consulted, and he had these skin findings. Here on the left side, we see very impressive cuticular hypertrophy over the index and middle fingers, right here. Here on the right side, we see this hyperkeratosis that involves the distal fingers, and we can even see it tracking here a bit along the medial aspect of the index finger. When we looked at the backs of his hands, we saw these erythematous to violaceous macules versus papules over the MCP joints, as well as here over the PIP joints. Now, the backs of the hands is a very classic location we look for in dermatomyositis, looking for those characteristic Gautrens papules. But in this patient's case, when we're considering the MDA5 variant, we want to flip the hands over. So this is a picture from his medical record, and we can see that he has these hyperkeratotic papules that are very much accentuated within the skin folds on the palm of the hand. When we look at his elbows, we see this reticulate appearing violaceous to erythematous patch versus plaque overlying the elbow, almost reminiscent of retiform purpura. And then here's a picture of his toes. We see some erythematous macules or papules here on the dorsal aspects of the toes and hugging the periungual skin. And this feature alone wouldn't necessarily be diagnostic, but just like we flipped over the hands, we would also want to flip over the feet to see if there were any findings on the palms of the feet, or soles of the feet. Now, when we're doing our complete skin exam in dermatology and we're considering a diagnosis of dermatomyositis, we really want to look head to toe. So we're looking in the scalp for alopecia and rash. We're looking in the oral mucosa for any ulcerations. We're looking at the trunk, the sides of the thighs, as well as the hands, feet. And those are very typical areas for searching for dermatomyositis. Now, my colleague saw this patient on April 1st and commented that although the skin findings are not very impressive, his few clinical findings could very well be subtle findings in dermatomyositis, including one of the amyopathic dermatomyositis variants with interstitial lung disease. Now, his prior biopsy was obtained for review. This was a punch biopsy done on the left elbow, and it showed two different types of reaction patterns. There was a spongiotic dermatitis, and this is a typical pattern seen in eczematous conditions like atopic dermatitis or allergic contact dermatitis. And a lichenoid dermatitis was also seen, and this pattern is seen in diagnoses like lichen planus or a lichenoid drug eruption. And all of these diagnoses don't quite match with what the patient's clinical presentation was. And so when this is the case, we really need to work critically and think critically about our clinical pathologic correlation. A couple questions will come to mind. Do we need to rebiopsy? Do we select a representative area? Or do we really go with our clinical judgment? And in cases of dermatomyositis, in my practice, it's really the clinical impression that gives away this diagnosis. And so in this case, I would say that it's likely that the clinical impression would take it away from me. Now, what might you see if you did biopsy a typical Gotrins papule of dermatomyositis? It would show a vacuolar interface dermatitis, so slightly different than a lichenoid dermatitis. And then this pathology report also comments that features of an autoimmune blistering disease or a blistering disease called dermatitis herpetiformis, which we see in association with celiac, was not identified. And that comment was likely made because that's what the dermatologist was thinking might be on the differential at the time. And then it comments that correlation with the direct immunofluorescence testing is recommended. And I just wanted to review briefly what direct immunofluorescence testing is. So here we see on the left side, H&E stain of a skin biopsy that shows dermatitis herpetiformis. We see these characteristic neutrophils in the dermal papilla and subepidermal vesiculation. And let me just step back a sec to orient you. So here we have the epidermis here in pink, and below it we have the dermis. And this is the junction of the dermis and the epidermis. And when we see an interface process, we see that that happens here at the junction of the dermis and the epidermis. But also in certain blistering conditions, you can have involvement here at the junction of the dermis and the epidermis, like in dermatitis herpetiformis, as well as in things like bullous pemphigoid. And here on the right, we can see immunofluorescence testing. And here in dermatitis herpetiformis, the deposition is granular IgA deposition within the dermal papilla. So what other circumstances might direct immunofluorescence testing be helpful? So we use it when we are trying to evaluate for cutaneous lupus, autoimmune blistering diseases, as well as certain types of vasculitis. In my practice, I don't typically use direct immunofluorescence for the diagnosis of dermatomyositis, as it hasn't yet been found to have specific findings to help really steer us towards that diagnosis, but it might be helpful if cutaneous lupus was in your differential diagnosis.
So on 4/6/2020, the myositis panel returned, and it showed a positive and strong positive MDA5 antibody. And then rheumatology at this time thought that this was likely consistent with MDA5 amyopathic dermatomyositis with rapidly progressive interstitial lung disease. Unfortunately, despite pulse steroids, plasmapheresis, tacrolimus, cyclophosphamide, all of these, the patient did not show improvement, and the decision was made to transition to comfort care. Support was withdrawn on 4/10/2020, and the patient expired 25 days after his admission to the hospital and approximately 67 days after his symptoms began, as far as we can tell from chart review. So why discuss this case at this grand rounds? Well, MDA5 dermatomyositis is a classic crossover between dermatology and rheumatology. It's fairly rare, but we seem to be seeing quite a few cases over the last few years. The myositis panel can also take up to 2 weeks to return, as it did in this case, so early identification might be helpful for rapid diagnosis and patient survival. It should also be noted that at UC Rheumatology, we have a bit more access to how the testing is run, and sometimes we can try to put a rush on things. Also at Memorial, these resources are not as present. So in fact, at this time, there was no inpatient dermatology or rheumatology available. This case also illustrates how subtle some of our diseases can be. And then I really think it's interesting that this all happened in the backdrop of a new COVID-19 pandemic, when essentially we were all learning our way through the pandemic and what presentation these patients would have. I'm also going to go into later in this talk some of the striking similarities between the rapidly progressive lung disease of MDA5 and that of COVID-19. Also, this patient was in and out of isolation during his admission, so this could have limited some identification or further identification of his rash.
So I'm going to transition into the next portion of our talk, which is going to cover these 5 learning objectives. So first, we hope that you'll understand what patients would benefit from care in a multidisciplinary dermatology and rheumatology clinic, that you will become familiar with the characteristic skin findings of dermatomyositis, particularly MDA5 dermatomyositis, and to be aware of systemic complications of this disease, to become familiar more generally with MDA5 dermatomyositis with some of the risk factors for severe disease, identify some similarities between MDA5 DM and COVID-19, and then finally recognize pernio and understand its association with COVID, including long COVID and recurrent pernio. So we're going to move into our agenda, starting with the dermatology-rheumatology partnership.
So what kind of diseases are a crossover between rheumatology and dermatology? Well, there are many, and here's a sort of short list of some of the most known diseases that can have both dermatologic and rheumatologic manifestations. Next slide. So systemic lupus is one that we're probably all somewhat aware of, and I have a number of pictures of lupus patients here. In the upper left-hand corner, we see a patient with classic photosensitivity, where you can see the sparing of where either the bra or the bathing suit was present. In the lower left-hand corner, we see a gentleman with discoid lupus, where you can see he has very impressive rash, particularly along his scalp, and this causes a scarring alopecia, and it is unlikely that his hair will return back because the hair follicles are damaged. In the middle slide, we have someone who has a desquamative lupus erythematosus, which can look like a skin reaction to some type of medication. In the upper right-hand corner, we can see one of my patients who has oral ulcerations, and you wouldn't know those were there if you didn't ask her to open her mouth because they're typically painless. And in the right lower hand corner is another one of my patients who has severe discoid disease. She's actually lost quite a bit of hair, which isn't as evident in this picture, but as you can see, it can be rather disfiguring. Next slide. Here's scleroderma, which is another common dermatology-rheumatology overlap. Up in the left-hand corner, we see Raynaud's phenomenon, which is a vasospastic disease involving the distal fingertips. And then moving over to the right upper, we see sclerodactyly, which with narrowing of the fingertips and contractures. We call that telescoping of the fingers. And then in the lower left-hand corner, we see one of my patients who has very impressive diffuse telangiectasias all over her face. And then a close-up of telangiectasias are located in the bottom middle. And you can see these are dilated blood vessels, but they're still connected. So if you push on them with your finger, they'll disappear and then refill as you remove your finger. And then on the right lower, we can see someone who has diffuse skin tightening of the chest and face. Next slide. So vasculitis is another one that we often see together. And here you can see a couple of images of palpable purpura, which tend to be in dependent areas and are raised in nature as they represent hemorrhage, which inflammation causes the blood vessel to break down and essentially blood to leak out. In the upper right-hand corner, we can see digital necrosis, and that's from a medium vessel vasculitis, typically affecting the digital artery. Next slide. So other areas that can be covered by dermatology-rheumatology clinic would be, for example, a dermatologic response to a rheumatologic medication. Most people know that we can use TNF-alpha inhibition for various diseases like rheumatoid arthritis and psoriasis and psoriatic arthritis. But interestingly, there's a paradoxical reaction which can happen when you use a TNF-alpha inhibitor, where you develop rather severe and diffuse psoriasis from the medication. So this would be another example of something that we could take care of in our clinic. Here are two patients that are seen in our clinic. On the left lower, we see a patient who has a history of lupus as well as scleroderma, and she presented with this indurated erythematous lesion along her right lower leg with an eschar in the middle, and the differential included infection versus some finding associated with lupus, such as deep fat necrosis like paniculitis. The other leg on the right is a patient who's well known to the inpatient service who has very severe lupus and cryoglobulinemia and vasculitis. And she presented with these punched out erythematous lesions along her lower legs. The differential of this was vasculitis versus infection versus venous stasis ulceration. So rheumatology is particularly well suited for having multidisciplinary clinics because our diseases seem to cover so many organ systems. So aside from dermatology rheumatology clinic, we also have rheumatology ophthalmology clinic with Drs. Kolfenbach and Dr. Palestine, rheumatology renal clinic with myself and Dr. Young, interstitial lung disease clinic with Dr. Griffith and Dr. Lee. And then there are actually even plans for a high-risk OBGYN clinic for pregnant patients who have renal and rheumatology issues.
In dermatology, we just have one additional joint clinic, and that's the overlap of dermatology and oncology covering cutaneous lymphoma with Dr. Pacheco and Dr. Haverkos that occurs weekly. Now I'm going to take a dive into our dermatology rheumatology clinic. We started this clinic in May of 2019 with 2 half days per month, and we continue to see patients on the first and third Tuesday morning of the month. Initially, Dr. Zell and Dr. Newman had a skin lupus and vasculitis focus, and Dr. Kuhn and myself were seeing patients with psoriatic disease and inflammatory bowel disease associated skin and joint manifestations. With Dr. Newman's recent sad departure, I've been taking over the dermatology side of things, and I'm just so glad to be working alongside such wonderful rheumatology colleagues to take care of patients with the spectrum of rheum derm diseases. The clinic is housed in rheumatology, scheduled through referrals to rheumatology, and appointments are made by the rheumatology staff, and we're very appreciative of all of this. We held 15 clinics in 2019, 24 clinics in 2020, and 18 clinics to date in 2021. Dermatology performs approximately 2 biopsies per clinic, and wait time for a new patient is currently 2 months. We've seen over 190 unique patients. Most of them are women. The median age is 44, and the most common diagnoses we've been seeing are lupus, psoriatic disease, rheumatoid arthritis, and dermatomyositis. Now, where do rheum referrals come from for rheum derm clinic? So rheumatologists here at the university and in the community can refer to dermatology for derm-only consults to see if a patient's skin condition can potentially be associated with their underlying autoimmune disease. So there are a couple derm-only slots throughout the morning for that. New referrals to rheumatology are screened, and for those that seem to have a flavor of a rheum derm overlap, those patients are slotted into the combined clinic. And then finally, new referrals from rheumatologists in the community or rheumatologists here at CU who would like our input on diagnosis and or management can have their patients seen in our combined clinic. The rheumatologists see patients in 30-minute appointment slots, and in dermatology, we have 20-minute appointment slots for new or follow-up patients.
So what are the benefits of having a joint clinic? Well, obviously, better communication between the two providers and data sharing. It can also be helpful in terms of choice of immunosuppressive therapy, so that we're not siloing the care of the patient with each person giving a medicine to just cover their only manifestation. So for example, if we have a patient who has a history of lupus nephritis and skin disease, Dr. Wallace and I can speak together to try to pick a medicine that can cover both. We have real-time decision-making, and labs can be done at each visit and not repeated over and over again, as often happens with patients who see multiple providers. Dermatology can also help us identify the many mimickers of rheumatologic disease that do not require immunosuppression. So that helps us minimize medications that can be deleterious for the patient. My guess is, although this hasn't been studied and maybe should be, is that we're better at reaching quality measures as well in clinic. So my guess is that our immunization rate would be high, and we're also better at counseling patients on risk for medications. Finally, I think it is an excellent opportunity for teaching our trainees. We have fellows, medical students, and residents that rotate with us. And in some situations, there are graduating rheumatologists or dermatologists who might be in areas where the other specialty is not available, so they have some background knowledge of the other's condition. There are some downsides as well. So only certain providers are interested in staffing joint clinics, and a patient may not prefer one of those providers. Also, providers need to be able to work together in a collaborative fashion. The other thing as far as referrals is it's sometimes it's hard to ascertain if both specialties are really needed. For example, we might receive a referral for a lupus patient who has severe skin disease. By the time they're booked into clinic, the skin disease has resolved. So we need to figure out how to vet these referrals appropriately. And then in the same vein, what do we do when one of the issues has subsided? A patient who is brought to our clinic with both skin disease and active lupus, but the skin disease has resolved. Now we need to move them into the general rheumatology clinic, and my current wait is about 2 to 3 months. Also, some logistics I thought might be worth mentioning. So we have to figure out who triages the patients. In our case, it is rheumatology. Which nurse should handle telephone calls from the patients? Which provider should chime in first in response to patient questions? Which department takes care of prior authorizations, which is quite a burden on nursing, as we do write for many medications that require prior auths, like immunosuppressives, medicines like sildenafil or thalidomide. Also, who writes for infusion orders and handles the calls from the infusion center, as we do write for things like IVIG, cyclophosphamide, and Remicade. So now we're going to move into some of the literature out there on dermatology, rheumatology clinics. And first, I'm going to take a stop in focusing on patients with psoriasis. So on the left, you can see someone who has some plaque psoriasis. And on the right, you can see someone who has arthritis associated with psoriasis, where we see this sort of telescoping of the digits where they become shorter due to how destructive the arthritis might be. Okay. So about 3% of the adult population has psoriasis. Psoriatic arthritis is seen in a variable number in patients who have psoriasis, somewhere between 6 and 42%. But we also can see psoriatic arthritis in patients who simply have a family history of psoriasis, but no skin lesions, or patients who only have nail psoriasis, for example. And we do believe that there's a high prevalence of undiagnosed disease. So in patients with psoriasis, about 15 to 20% we think have undiagnosed psoriatic arthritis. In one study of derm rheum providers, they found that the percent using only topical medications decreased, and the amount using biologics and non-biologics disease modifying medications increased, with clinical improvements in most, 82%. There is a large consortium of dermatology rheumatology clinics that are really dedicated to psoriasis in the US called the Pac-Man Network. And they have found improved communication between providers and more accurate diagnoses. So now I'm going to move the scope back and talk more generally. So where do the referrals come from? Well, mostly rheumatologists refer to derm rheum, but we also see a fair amount from dermatologists. And in this case, 17% came from primary care. And that's what we're hoping to increase, partially by giving this grand rounds today. And then 2.7% from other specialties. And again, we do see patients leaving with a new or refined diagnosis.
So I'm also going to briefly talk about combined rheumatology, dermatology clinic data. So I really liked this point that a 2014 study out of the Dartmouth Combined Clinic that they made, that managing skin lesions in patients with known or possible autoimmune diseases can really be a diagnostic and therapeutic challenge which often requires the combined expertise of dermatology and rheumatology. And this is backed by the point that they had 61% of patients having a change in diagnosis and treatment as a result of a visit to this combined clinic. And I just find that a pretty staggering statistic. In 2016, out of Canada, these authors noted that it's important to be aware that skin problems in rheumatologic patients are not always related to the underlying condition. And Dr. Zell already touched on this. This clinic found that the most common dermatologic diagnoses were dermatitis, which doesn't have a specific associated rheumatologic disease, but also psoriasis and cutaneous lupus, whereas the most common rheumatologic diagnoses were lupus, RA, psoriatic arthritis, and undifferentiated connective tissue disease. And then finally, in 2009, out of the Yukon Combined Clinic, they surveyed their patient for satisfaction with the combined clinic, and they found a high degree of satisfaction and a high degree of likelihood of returning to the combined clinic. These patients, about a third of them received a new or revised diagnosis, and the majority, 71% of patients, were given a new or modified therapy. And again, considering those medications that we use to modulate or suppress the immune system, this is really significant and something to note. So we're going to move into talking about dermatomyositis.
So here's some pictures that we see in patients who have dermatomyositis, and I'm not going to go into them in detail as Dr. Wallace will cover this in the future. So dermatomyositis comes in a number of different flavors, if you will. There's juvenile dermatomyositis, dermatomyositis associated with cancer, and then kind of your typical dermatomyositis where we see inflammation of muscle and skin findings and occasional interstitial lung disease.
So now I'm going to jump into some classic skin signs of dermatomyositis. So this is a woman who presented to our clinic with a history of a refractory allergic contact dermatitis to oral steroids. And when she walked into our clinic, we were just struck by this impressive periorbital erythema. And this periorbital erythema is called the heliotrope rash of dermatomyositis. And this is often accompanied by this periorbital edema. And I also just want to pause and talk about her facial erythema, which doesn't have a pathogen. But if your differential includes the malar rash of acute lupus, I just want to point out that this facial rash of dermatomyositis, so my cursor here, crosses over the nasolabial fold and even affects the sun protected area of the upper cutaneous slit. While in the butterfly rash of acute lupus, this really respects this nasolabial fold and very rarely would ever cross this boundary. So this patient has a very characteristic facial erythema of dermatomyositis as well. This patient also had the characteristic V-neck rash of dermatomyositis. And similarly, we can see this violaceous erythema on the upper back covering the shoulders of patients with dermatomyositis. And it's not so infrequent that I also see this rash track down the entire back. Gottrin's sign are these erythematous to violaceous papules and plaques, oftentimes with overlying scale, located on the extensor surfaces of the joints. So we see these often on the elbows and the knees. And then Gottrin's papules are these violaceous to erythematous, sometimes scaly papules that overlie the MCP and interphalangeal joints. And we can see in this patient who has quite extensive skin disease, you can actually see a connection between the Gottrin's papules just because of how exuberant and active their dermatomyositis is. This is the Samet sign, or these dystrophic and ragged cuticles. And we can see that this patient, just like our patient in the case, has cuticular hypertrophy. Now, one thing we can also appreciate in this patient is that you can see these dilated capillary loops. Oftentimes we need our dermatoscope or a magnifying device to help see these dilated capillary loops which alternate with capillary loop dropout. But when cases are pretty exuberant or impressive like this, we can even see them with the naked eye. And finally, this is the Holster sign, this violaceous erythema along the outer thigh. And we can similarly see this violaceous erythema on the upper outer arm. And then as I was mentioning earlier, don't forget to check the scalp. These patients can have quite fluorescent violaceous erythema of the scalp, and this tends to be overall pretty itchy. So this is just a summary of the signs that I'm not going to dive back into, but hopefully this is helpful for you recognizing patients who walk in the door with more textbook dermatomyositis.
So now we're going to focus on the amyopathic dermatomyositis, who are patients who have very minimal elevations of muscle enzyme or no elevation of muscle enzyme, but classic skin manifestations of dermatomyositis plus or minus interstitial lung disease. So here's an example of the array of autoantibodies that can be seen in myositis. And these antibodies can provide a window into what kind of phenotype a patient with dermatomyositis might have. As you can see, some antibodies seem to predict more lung disease versus skin disease versus CTD overlap. Our patient presented at the beginning of this did have an MDA5 antibody and an anti-Rho, which I will get into a bit later. So now we're going to talk about MDA dermatomyositis in more detail. So actually, you might recognize this picture from the New England Journal. It's one of Dr. Wallace's patients who will take us through his course later in the talk. So dermatomyositis of the MDA5 variant has a very interesting story. So they used to call it clinically amyopathic dermatomyositis because of the low creatinine kinase seen in these patients. But then in 2005, in a Japanese cohort, they noticed that of 15 patients who had the clinically amyopathic variant, 8 of them seemed to have antibodies to the same 140 kilodalton protein. This protein was later found to be MDA5. The degree at which we see MDA5 in dermatomyositis varies on which part of the world you are in. We see it about 7 to 10% in European cohorts, but a little bit higher in Asia. So this is from that study. And I just wanted to point out that the patients who did have the antibody to the 140 kilodalton protein had a 50% chance of having rapidly progressive interstitial lung disease, where only 6% of the patients who did not have the antibody had that manifestation. So MDA5 stands for melanoma differentiation associated gene 5, and it's a cytoplasmic viral double-stranded RNA receptor that's involved in the innate immune system that causes the production of type 1 interferon. This is a proposed mechanism. We actually really don't know, but we believe that viral RNA enters the cell and interacts with this MDA5 receptor and then causes downstream signaling to produce type 1 interferon. We also think that that protein, that receptor, somehow gets exported from the cell and then gets modified within the immune system and presented as antigen to develop antibodies to MDA5. Diagnosis can be challenging, as many patients who present with rapidly progressive lung disease, it looks like ARDS, which can be caused by a variety of etiologies. Some patients can also have very mild or no skin findings. But for those who do have rapidly progressive ILD, most fatalities occur within the first 6 months, so it can happen quickly. The 6-month mortality rate is somewhere around 33 to 66%, but the outcome depends on risk factors that I'm going to get into. Emerging data does suggest that early and aggressive treatment might be beneficial.
So here is just a very brief overview of those myositis-specific autoantibodies. I just want to briefly mention that dermatomyositis patients overall have an elevated risk of malignancy, so they all need to be screened for malignancy, but those 2 particular autoantibodies, the TIF1 gamma and NXP2, have a greater associated risk of malignancy, so we need to keep an eye out for those patients. Patients with anti-Ku can have an overlap between dermatomyositis and scleroderma, and patients with anti-MI2 have skin-predominant disease. Now, I'm going to dive into the skin manifestations of anti-MDA5 dermatomyositis, which is associated with rapidly progressive interstitial lung disease, as Dr. Zell has already mentioned. So here are some more textbook clinical images of MDA5 dermatomyositis. So this is a young woman who has children and is a hairdresser who presented initially with some pain in the joints of her hands, and she was initially diagnosed with rheumatoid arthritis. She then developed these ulcerations over the backs of her hands, and she was felt to have vasculitis, and so she was put on immunosuppressive therapy. And then she presented to our clinic with these skin findings in the context of immunosuppressive therapy. And here we can see on our exam that she has ulcerations over the Gautrins papules on the MCP joints and several of the PIP joints. Now, as I mentioned in our case, we really want to flip the hands over to look at the palms. So here we can see on this young woman's palms that she has these palmar papules and macules that have a predilection for the skin folds. And she also has these distal and middle of the finger ulcerations. And these are characteristic painful palmar papules of MDA5 dermatomyositis. So we also want to look in the oral mucosa in this phenotype of dermatomyositis because they can get oral ulcerations anywhere in the oral cavity. And this patient also had diffuse non-scarring alopecia, which can be seen in this variant that is typically very responsive to therapy. Now here's another patient. She has what looks like very characteristic findings of just typical cutaneous dermatomyositis. She has those Gauthrin's papules over several of the MCP and interphalangeal joints. But when you ask her to flip her hands over, you see these very characteristic palmar macules and papules that are painful with a real distinct predilection for those skin creases. And this is another patient with an MDA5 variant who hasn't yet ulcerated. And not all of these patients will go on to ulcerate over the Gauthrin's papules and Gauthrin sign. Another patient, a Hispanic patient with very minimal skin findings on the dorsal hands, looks, reminiscent of Gauthrin's papules. But again, when you ask her to flip the hands over, we see that there's this almost retiform appearing purpura here on the thumb. And we see these very shiny, painful palmar macules and papules characteristic of anti-MDA5 dermatomyositis. This is a lady I met on the inpatient consult service during training. She had a history of interstitial lung disease, was on oxygen, and really had not been given a conclusive diagnosis as to why she had experienced that or was suffering from that. And we were consulted for these hand findings, and we can see that she has these painful palmar macules. She has several areas of ulcerations, as well as early digital necrosis and impending necrosis on several of her fingertips. And with immunosuppressive therapy, as well as vasculopathy therapy, we saved 2 of her 3 fingertips, and she was diagnosed with the MDA5 variant of dermatomyositis. And this is the final case that I'm going to go through. This is a gentleman who was a speaker. He also had the very characteristic history where he developed this kind of odd, nonspecific inflammatory type arthritis. He also suddenly developed shortness of breath with interstitial lung disease. And then he was put on immunosuppressive therapy and came to our clinic with these skin findings. And here we can see, starting at the top, he has this non-scarring alopecia here on the top of the scalp. He has a heliotrope rash. He has some mid-facial erythema that's crossing over the nasolabial folds. Here we see oral ulcerations, and then finally we see early ulceration over the Gauthrin sign. And then when we take a look at his hands, these are the most striking findings we see, these ulcerations over the Gauthrin's papules. So when this patient came to clinic, we confirmed the diagnosis of MDA5 dermatomyositis. We made that clinically. Of course, a myositis panel was sent off, and we do this for all patients who are suspected of having dermatomyositis. So it really helps us to find out what their phenotype is and keep an eye out for what they might be at risk for. And then in this patient, in addition to escalating his immunosuppressive therapy to protect his lungs, we also started him on vasculopathy therapy to address these ulcerations. And so this is 1 month after we saw him. We can already see this impressive improvement in those ulcerations. 2 months. And then finally 4 months, we can see he is nearly completely healed. So what did we do for this patient? So see, these are some treatment considerations in anti-MDA5 dermatomyositis. So for the ulcerations, it's essential to incorporate therapies that are aimed at managing vasculopathy. We use medications like nifedipine and sildenafil to help with vasodilation. We use pentoxifylline and aspirin to help with blood flow. And then we also use botulinum toxin. Now, botulinum toxin has been studied in Raynaud's in digital ulcerations related to scleroderma, but we've also started to use it in anti-MDA5 dermatomyositis patients who experience ulcerations. And so in this patient, we got him started on sildenafil, pentoxifylline, aspirin, and then we injected Botox onto the lateral aspects of the most involved digits with ulcerations. And really within days after the botulinum toxin, he started to have relief of pain. And as you can see over the course of the 4 months, he had significant improvement in his ulcerations. And now I just also want to comment that these patients are very, very sick. They really require multidisciplinary care with pulmonology, rheumatology, and then in dermatology, really try and provide synergistic and adjunctive therapies to help with their skin. But really addressing the interstitial lung disease is the most important component. And therefore, multidisciplinary care is just so essential in these patients. And so individuals have looked at the histopathology of these MDA5 dermatomyositis skin lesions. And when they biopsied the palmar papules, they found what is termed a vasculopathy. So vasculopathy is a general term to define kind of changes to the blood vessels, while vasculitis is a more specific term to describe inflammation of the blood vessels. And here we can see that on the left side, there is inflammation within the medium-sized vessel of the dermis. And here on the right side, we can see that within a small vessel, there's some fibrin plugging within the vessel. And these are changes of those palmar papules of MDA5 dermatomyositis skin lesions. And that's really one thing that's supported our use of vasculopathy therapy in these patients. And so just to very briefly review, I've reviewed kind of 4 distinctive skin manifestations of dermatomyositis, and I just want to MDA5 dermatomyositis, and then I just want to quickly circle back to our case. Down here, these patients with anti-MDA5 dermatomyositis can also have this hyperkeratosis overlying the fingers that almost looks or resembles mechanics hands, and we typically associated mechanics hands with the anti-synthetase syndrome, but MDA5 dermatomyositis patients can almost have a mechanics hands light. Like it's not quite as impressive as the mechanics hands, but it can certainly still be there. And so don't forget that as one of your clues for the skin findings of MDA5 dermatomyositis.
So of course, there are other features aside from skin of MDA5 dermatomyositis. We often see liver dysfunction. We see arthralgia and arthritis fairly commonly. Interstitial lung disease is common. And then this rapidly progressive interstitial lung disease is a bit less common, but definitely present. It's a non-specific pattern. It's associated with an increased risk of death. And interestingly, it has an inverse relationship with malignancy. Many of you may know that dermatomyositis seems to have an increased association with malignancy, but for some reason, interstitial lung disease seems to lower that. Pneumomediastinum is another manifestation that we sometimes see, and this is rare in regular old dermatomyositis. It is associated with a mortality risk and also cutaneous ulceration. We can also see hoarseness, sore throat, or dysphagia. So thinking about outcomes of patients who are positive for MDA5, it's important to watch for the rapidly progressive interstitial lung disease. So this was a study out of China where they looked at 90 folks who were positive for MDA5, and they either had clinically amyopathic dermatomyositis, or polymyositis, and followed them for 2 years. Interestingly, like our patient, 71% of them were also SSA positive. 90% of the patients presented with ILD when they were diagnosed, and 40% were diagnosed with a rapidly progressive ILD. Mortality rate at 6 months was about 25%, mostly from respiratory failure. And then what they did is they compared those who survived with those who did not over the study period. So the patients that had an increased risk of death were those who had an elevated serum ferritin, an elevated CRP and ESR, a lymphopenia, a positive Ro52, which our patient had, and then worse scores when assessing for CT distribution of lung disease. There have also been other studies that have looked for markers for poor outcome of MDA5. In another study, they were more specific and said that ferritin levels greater than 636 nanograms per mil predicted poor outcomes, LDH levels that were greater than 355. And then this is interesting, and maybe Liz, you'll help me point in this little diagram up on the right, pulmonary function testing at presentation. They divided them into 2 groups, early stage and advanced stage. So when they did pulmonary function testing, if your forced vital capacity was greater than 50%, then your mortality rate was fairly low at about 15%. But if when you presented, you were either too sick to perform PFTs or your FVC was less than 50%, then that put you in that advanced stage, and it seemed as though your mortality rate was much higher. Also, it appears that high MDA5 levels may predict poor outcomes. At the university, we only get a low positive, a positive, and a high positive. But in some of the other scales, they have more gradations to that. So just a word about this Ro52. So it's kind of confusing, but when you send an ANA and you have a reflex to a panel, your SSA may come back as positive. But maybe you didn't know that you're actually getting antibodies to 2 different proteins, Ro52 and Ro60. At one time, it was thought that they were more involved with each other, but they're actually separate proteins. But you'll only get a positive if either one of them or both of them are positive. And these are associated with Sjogren's syndrome and systemic lupus and sometimes rheumatoid arthritis. but it's sort of clumped together in the way that we study them. Rho52 is interesting. It seems to induce interferon. It's located in the nucleus and the nucleolus, and it's been associated with myositis. And in fact, in some studies of interstitial lung disease, patients who had a positive Rho52 were associated with more severe disease. We call this now a myositis-associated antibody, which means that it's not only associated with myositis, but it seems to play somewhat of a role. So if you have a patient who is positive for MDA5, what kind of workup should you do? Well, first and foremost, you need to make sure they don't have interstitial lung disease. So a high-res CT, pulmonary function testing, and oxygen saturation would be great as a start. Assuming all of those look okay, then Dr. Wallace and I can take care of the skin findings in the dermatology rheumatology clinic. So now I'm just going to talk very briefly about some of the similarities between MDA5 dermatomyositis and the presentations of COVID-19, because I think it's incredibly interesting. So there are a lot of similarities between the severe forms of both of these diseases. They both can have involvement of lung and skin. They both can be associated with systemic inflammation from a variety of mediators, and they both can have progressive pulmonary predominant disease. So this was a chart that was published in 2020, but here you can see, next slide, that there are a couple areas that are interesting. So they both seem to be triggered by viral infections. They both have similar cytokine profiles. And as far as treatment, there may even be treatments that may be similar. And then even after this article is published, there are other things that came out as well. They both can cause elevated lactate dehydrogenase levels. They both can cause elevated ferritin. And so it does bring up whether or not maybe there's a similar pathway going on with both of these diseases. Next slide. And then to support this more, so there was a study in Wuhan during really the height of the pandemic, and they had 274 patients with COVID-19. 77 had fairly severe disease, 11% in the ICU, and 17.5% died. They ran an ELISA, they ran an ELISA for MDA5 and sent it on all of these patients. Now, it should be said that we usually use an immunoblot, and they used a lower cutoff than we do in the US. However, the rate of positive testing was 48.2%. MDA5 positive patients also fared worse than those who were negative, and the titer of the MDA5, as described previously, was also inversely correlated with survival. And then I was doing some other digging, and it does suggest, there is data to suggest that COVID infections do interact with the MDA5 receptor, which makes sense why some of the downstream mechanisms and findings seem to be the same.
Great, and I'm just going to wrap up with a few more moments about other COVID-19 skin findings. So we've been seeing patients in the dermatology rheumatology clinic that have joint and skin manifestations that have questioned whether or not they're associated with COVID-19 infection. And so I just wanted to briefly touch on pernio. We've been seeing a ton of pernio. So it's also known as chilblains. This is distinct from lupus pernio, which is a type of cutaneous sarcoidosis. And here on exam, we can see these erythematous to violaceous macules. Again, macules are flat, papules are raised, plaques and nodules on the acral surfaces. So it has a predilection for the toes and the hands. This typically occurs with pain, burning, or even itching. It often occurs about 12 to 24 hours in the acute presentation after cold or a cold, wet environment like a damp sock after hiking exposure. And then it typically resolves over the following couple weeks. Now, there can be primary pernio, which is often seen in younger individuals, typically women, but there can also be secondary pernio, which is due to an underlying disease. So things that have been associated with pernio include hematologic malignancies, autoimmune disease, viral infections, as well as malignancy. Now, data isn't sufficient to support the association with all of these, but I just do want to mention that chilblain lupus erythematosus are skin lesions that are clinically consistent with pernio that are seen in patients who have been diagnosed with systemic lupus. Now, the pathophysiology of pernio is a bit unclear, but one hypothesis is that there's an abnormal vascular response to cold exposure. So cold exposure leads to vasoconstriction or vasospasm that results in hypoxemia, and that stimulates a local inflammatory response. And we are not really often biopsying pernio. This is really a clinical diagnosis for which biopsy is safe for those atypical cases. But I just want to show here that there's this perivascular and oftentimes perieccrine lymphoid infiltrate with this papillary dermal edema and this edema surrounding the blood vessels. Now, how do we manage pernio? We really emphasize peripheral warmth, but core warmth is just as important, so we can warm the core and send the blood to the peripheries, avoiding those known exposures, smoking cessation, high potency topical corticosteroids, because there is that inflammatory component to it. And for those patients with severe refractory or recurrent disease, considering systemic therapy like nifedipine. Now, I couldn't exit this talk without talking about COVID toes. So what has been the association between COVID-19 infection and pernio? The punchline is the relationship has really not been confirmed and it's still under investigation. We saw a surge in cases of pernio, but a lot of these patients were COVID serologies, PCR antibody testing were often negative. The hypothesis is that pernio may be the cutaneous expression of a type 1 interferon response, and generally this has portended a good course or a more indolent course in patients who develop pernio. Now, another hypothesis for why we're seeing this so much during the pandemic is that people have been living sedentary lifestyles at home. They're often walking around their home barefoot, consuming energy drinks, or perhaps engaging in recreational drug use. And all of those things may have led to increased cases of pernio. And so just two brief emerging phenomenon with COVID in the skin. First is recurrent pernio. So there's been some case series about patients who developed pernio during the initial phases of COVID-19. About 33% of these patients had laboratory confirmed infection between March and May here in 2020. And then later on in 2020, even though they didn't necessarily have any symptoms or laboratory confirmation of COVID, they developed recurrent pernio. And so we're keeping an eye on this. Why are these patients developing recurrent pernio? And then finally, you've likely heard about long COVID, the long haulers, patients who experience persistent symptoms after many days after PCR positivity. Long COVID is also being investigated in the skin. And we can see here from this registry data that pernio is the skin manifestation that has the highest cases of long haulers. We can see among all patients in this registry data study that about 7 had long hauler symptoms. And of those who are lab confirmed, 2 of those 7 were long hauler cases. Now, I'm just going to jump in briefly to these other skin findings that we're finding with COVID infection. So these are just a smattering of photos of skin findings we're seeing with COVID infection. And this study is from a registry that was developed at Harvard by dermatologists at Mass General, and they collaborated with the American Academy of Dermatology and the International League of Dermatology and invited healthcare providers globally to submit cases where they had patients who had skin findings associated with confirmed or suspected COVID-19. And when they looked at how these patients fared depending on their skin manifestations, they found that patients with pernio were really infrequently hospitalized. And then they looked at the next bucket of patients who had vesicular, urticarial, macular erythema, or morbilliform eruptions, and about 22 to 45% of these patients were hospitalized. But in patients who developed retiform purpura, 100% of these patients were hospitalized and 82% had ARDS. And so this is a finding that I've seen on our consultative service here in the hospital. And I just want to kind of bring it back to the case where we mentioned that retiform purpura on that gentleman's elbow. And so the extremities and buttocks are affected. And so something not to miss in patients who are hospitalized with COVID. And with that, I just wanted to mention how to refer to the clinic again. You can place a referral to the to rheumatology and specify that you'd like your patient seen in the derm room clinic. And please don't hesitate to message either of us if there are any issues or delays with your referral. These are our emails. And then finally, some thank yous.
Sorry, we went a bit over.
Okay, well, thanks for that terrific presentation. We only have time for a couple of questions. Let me ask a couple. Is it possible to, or how frequently do you see the pulmonary manifestations of MDA5 disease prior to or without the skin manifestations of the disease?
It has been reported, or they'll say that the skin disease is incredibly mild. So I don't actually know what percentage. I mean, this is a tough one because very limited data on these patients. I mean, this is really something that we're learning about real time. So I would say, I mean, certainly anyone who presents with new ILD, a myositis panel is one of the most common things we send.
Yeah.
So because of that, I would say we do pick them up without skin disease sometimes.
The next question is, you showed us a couple of slides with a whole plethora of antibodies that could be sent. How do you decide which ones and how many to send based on your clinical acumen or suspicion, or is it a shotgun approach?
You know, it is a panel. It goes to ARUP usually. And so you will have all of those antibodies checked at once. The one antibody that I think you have to check separately is if you're worried that someone's been on a statin and they have a myopathy, you have to send the HMG-CoA reductase antibody separately, I believe. It depends on the panel.
Yeah.
But typically you will get all of those antibodies.
Okay, well, it's 1 o'clock. We want to stay on time. So thank you very much for the presentation, and appreciated all the pictures of the dermatologic lesions. Thank you.
If anyone has any questions, certainly you can email us too.
Absolutely.